Thank you everyone for returning to the third session of today's York Circle at Home lecture series. For those joining you, excuse me, for those of you joining us on the webinar now, welcome. It's a pleasure to have you join us for this online lecture. My name is Julie Lafford. I'm the Executive Director for Alumni Engagement at York University. For those of you who may have attended one of our morning sessions today, I realize you've already heard what I'm about to say, so thanks for bearing with me while I go through a few items for newcomers to this session. Believe me, the lecture at the end of it will be worth it. While the world has changed drastically since we hosted our last York Circle event on campus in February, we're pleased to continue to bring you this lecture series in a vital virtual format during the COVID-19 pandemic. As many of you know, York Circle is an opportunity to learn from some of the incredible faculty and researchers here at York University. We'll continue that today as you'll hear from some of the university's leading scholars, many of whom pivoted their own research to study the varying effects of this pandemic and draw from their expertise to speak to you today about its lasting impacts and how to navigate these changes. Even though we can't gather physically, we hope to continue to offer you programming and events virtually so that we can stay connected during this challenging time. First, I'd like to provide an update on some of the ways York is responding to the pandemic to support students and our communities. York has launched the COVID-19 Student Relief Fund, an initiative that will raise money to support York University emergency bursaries. This has been established to help York students cover unexpected housing, rent, food, travel, and other costs due to the pandemic. York has also issued a call for time-sensitive special research proposals with a COVID-19 focus. Funding in the amount of $250,000 will be provided by the university. Additionally, researchers and staff at York have come together to respond to the call for supplies to help Canada and Ontario combat COVID-19. During the pandemic, York has donated over 60,000 medical supplies from the faculties of Science, Health, and the School of Arts, Media, Performance, and Design. Although we aren't all in the same location right now, I'd still like to acknowledge that many Indigenous nations have long-standing relationships with the territories upon which York University campuses are located that precede the establishment of the university. York acknowledges its presence on the traditional territory of many Indigenous nations. This territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. Thank you again to all of you joining us remotely today. I want to give a particular shout out to the chair of York's Board of Governors, Paul Saparis. Paul, I noticed you were here this morning. Thank you for coming back this afternoon. I also noticed that Dr. Fuminori Toyosaki is one of our guest audience members today, and Dr. Toyosaki will be joining me for a Scholars Hub lecture on May 13th. And I look forward to that very much. Before we begin, I'd like to take a quick poll asking the audience, have you ever attended a York event before today? So that should come up on your screen now. Please take a moment to respond to that. Thank you for taking the time to do that. I'll share the results with you shortly. I do want to say that we have 83 people on the webinar right now, and I'm sure we'll have more joining us shortly. And it's really great to see so many of you taking some time out of your Saturday to spend it with us. I have the results right now. 86% of people have attended a York Circle event before, and we have 8 newcomers. Thank you so much for joining us today. It's great to have you here. If you are new to online events and you need help at any time with this experience or have questions about the content, please feel free to click on the Q&A button on the bottom of your screen. Our team is ready to help you. So now I'm pleased to welcome our guest speaker, Dr. Jane Heffernan. Dr. Heffernan is a professor of mathematics and statistics at York University, where she leads the Modeling Infection and Immunity Lab in the Center for Disease Modeling. Dr. Heffernan attained her Bachelor of Science in 2000 from Trent University, her Bachelor of Education at Queen's University in 2001, and she earned her Master of Science in 2002 and PhD in 2005, both at the University of Western Ontario. She then completed her postdoctoral fellowship at the University of Warwick in the UK in 2007. Her education was funded by the Natural Science and Engineering Research Council of Canada. Welcome, Dr. Heffernan, and thank you for joining us today.
Thank you so much for the nice introduction, and thank you everyone for joining me this afternoon to learn about mathematical modeling during COVID-19.
Over to you, Dr. Heffernan. Thanks again.
Thank you. So over the pandemic, we've seen quite a few mathematical models being mentioned in the news. And I thought that what would be great for us to discuss today and learn about today is what's in a model. Over the past couple of months, there have been lots of people who've been asking me, news reporters, neighbors, family members, what do you actually do? What's in a model? What do you do? What do you look for? What data do you use? What mathematical tools do you use? Are models right? And if a model is wrong, what does that mean? And so what I'm hoping to give you today is just a background, a little bit of an introduction to what mathematical modeling is, and then provide some discussion points of how to learn and understand from mathematical modeling results. Okay. So I am the director of the Modeling, Infection, and Immunity Lab in the Mathematics and Statistics Department at York, as well as within the Center for Disease Modeling. And I'm really interested in looking at how things that happen inside the body affect how you are susceptible or to a disease, or if you're infected, how what's happening inside your body affects how you might transmit the disease to other people. But then I'm also interested in looking at how the disease propagates in a city like Toronto, or in a province, or in a nation, or around the world, or even in smaller jurisdictions as well. But so you can really think about how a disease it infects individuals, but it transmits within the population. So it infects a population, which affects individuals through susceptibility and transmissibility, and then it infects individuals, which affect how a disease propagates in the population. And so really, I'm interested in many different things in this feedback loop. I'm interested in looking at what's happening really inside the body, the immune system and the virus, and how they interact. How then that generates to the studies of immunity and how protective that is and how it might wane over time. I'm interested in looking at how that translates to how people show symptoms and how severe their infection is. And then that really brings down to looking at the interventions of different pharmaceuticals like vaccines and drug therapies. And I'm also interested in looking at how people choose to uptake different behavior over time and how that is incited by mass media and by government announcements. And then overall, all infectious disease modelers are really interested in trying to understand all of the patterns of the different diseases all around the world, and then how these diseases present risk of importation and exportation between communities. So during COVID-19, I mainly have been focusing on looking at the effects of social distancing. So here, or physical distancing, which we've also been hearing it being called in the news. And so Canadians have been asked to social distance or physical distance, which is maintaining a distance of at least a hockey stick apart. So I've been looking at that, but I've also been looking quite a bit at how to use mathematical models to predict or to try to project demand on the healthcare sector. And then that translates into personal protective equipment supply. And so at the end of the presentation today, I'll touch a little bit on some of the work that I've been doing. So mathematical epidemiology is not new, and it really stems from three major studies in history that kind of made this field exist. So here are three individuals or three studies by John Snow, Ignaz Semmelweis, and Ronald Ross. And these were the first individuals really to understand how data can inform population level statistics in terms of an infectious disease, and then implement mitigation strategies and determine how effective a mitigation strategy can be. But these guys didn't actually use the type of mathematical models that we use today. The mathematical modeling structure, basic structure for mathematical epidemiology, was actually developed by Kermack and McKendrick in 1927, 32, and 1933. And it was republished in 1991 in the Bulletin of Mathematical Biology, if you're interested in looking at it. And what they did is they developed this model called the SIR model. And what that is that S stands for susceptible individuals. So here we have a compartment where everyone who's susceptible can be modeled in this compartment. Then we have individuals who are infected and infectious. They live in this I compartment. And then individuals can recover. And so this is what the equations look like, this basic model. And so what we're saying here is this ds by dt is delta S over delta T. So it's how the susceptible population changes with respect to time. And it reduces the susceptible population when an infected individual meets a susceptible individual. And then there's a transmission with this transmission rate beta that occurs between those two individuals. And then this individual now is taken away from the susceptible population and is moved into the infected compartment. And then they're in this infected compartment for 1 over gamma number of days on average, at which time they will then recover and move to the recovered compartment. And so what you can see here is that
I'm so sorry to interrupt you, but I think we're having a bit of a problem getting your slides up and running. So I've just been asked to mention that to you. Can you see if you're sharing your screen properly?
Yes, I can reshare it.
There we go. Okay, I'm sorry about that.
That's okay.
We've got you up and running now, so please go ahead. Thanks.
Okay, so this is the SIR model. And what we do here is we take the susceptible individuals and we can multiply them by the infected individuals with this transmission rate beta. And this is negative because when a susceptible individual becomes infected, they move away from the susceptible compartment and they get moved into the infected compartment here. And then the individual stays in the infected compartment for 1 over gamma number of days on average, at which time they move into the recovered compartment. So we have our susceptibles. They can become infected by this equation here, beta times S times I. And then the infected individuals can move to the recovered compartment with some rate gamma, where 1 over gamma is the average number or the average length of time that someone is infectious. And so what you can see here is our susceptible population will decline over time. Our infected population then will increase. And then when there aren't enough susceptibles around, it will start to decrease and go down to 0. And as it's going down to 0, the recovered compartment is also going to go up. And so the idea during coronavirus, during this time, is really that we're trying to flatten this red curve. Because what's happening is that this red curve can get so high that this is going to overburden our healthcare system. And we won't have enough, say, hospital beds for individuals to get the treatment that they need. And so what we really want is we want to see how this red curve can flatten. But really what happens then is it will flatten and then it will extend into time. So the peak will go down and then the end of the epidemic will move far into the future. And so that means that overall, there will be a reduction in the number of infections because we're social distancing, but we're moving all of this into the future. And so that means that social distancing will have to occur over a length of time, at which time, and then the time that it ends is when we see some threshold number being calculated. So So really what we're doing is we're looking at this delta S over delta T, and that really is just slope. So this is the basic of calculus, that we have delta S over delta T, ds by dt. And this is really just looking at the rise over the run, where here our run is time and our rise is these different populations, but they interact through the equations where we have this multiplication here. So that's the basic model of mathematical epidemiology, the SIR model. But we can use this model to extend into many different things and to keep track of all these other different types of compartments that we have in an infectious disease. So one thing that you might think about is that, well, when you become exposed to a pathogen through this interaction here, you're not necessarily infectious right away. So you might then have some time where you're in some other compartment called E. So that's your exposed compartment. Then you might also think, well, we know for coronavirus that there are individuals who are asymptomatically infected. And so we might need to then differentiate between those people that don't show symptoms and those who do. We might also need to differentiate between people who can stay home while they're infected versus needing to go to the hospital. So we have mild versus severe infections. And right now, there's also some discussion in terms of if someone was infected but asymptomatically or mildly infected, their immunity might not be as good compared to people who've recovered from a severe infection. And so that immunity might decay quickly over time. And then that would mean that some individuals may become susceptible to the disease again. So these are all things that we need to consider when we're looking at all these different compartments in the population. So here I have just a simple extension to the SIR model, as I have an SEIR model, where the E people, remember, are those people who are infected but aren't infectious yet, and they don't show any symptoms. And so here I have a population that we can use to visualize what's happening with an SEIR model. So we have some individuals that are infectious. They come into contact with these susceptible individuals, and then they can become exposed, which we have highlighted here in green. And then those exposed individuals can then become infectious, and our infectious individuals can recover and become red. And so you can think about this population as being some population that's kind of existing in a test tube or a petri dish, and it's being stirred. And so these individuals can come into contact with each other, or you can think that we might structure our population a little bit differently and put them in a network, and so that you have lots of connections to people who live in your household or your friends, and then you have your workplace connections, and then you have your broader community connections. So what we're actually really doing with social distancing is we're physically putting distance between us and all of our contacts. And so if you think about that, then what we're really doing is we're taking away all of these people that lie in between us and all of these other people as well. And so what we're doing is we're stopping this transmission chain of the disease happening. And that's really what that means in terms of flattening the curve. So we're flattening the curve, but we're extending the length of the epidemic so that our healthcare system can manage the healthcare demand burden. So one thing that you've probably heard a lot in the news is about the reproduction number. And so I thought that that'd be something that we should talk about here. So the reproduction number is defined as the number of secondary infections produced by an initial infective when introduced into a totally susceptible population. That's the basic reproduction number. And so that means, so here I am on the left, and say I'm infected with something, and I'm coughing, and here on the right are some other members of the Center for Disease Modeling at York University. And then you can see that maybe I've had contact with all 5 of these people, but I only successfully infected Dr. Mogadas and Dr. Zhu. And so then that means that the basic reproduction number is equal to 2. Well, what does that mean? Well, that means that in the time that I was infected, I made 2 more infections. And so I've doubled the number of infections in that amount of time. And so if everybody is making 2 more infections, then you can think that the population of infecteds is going to grow over time. But if I only make 1 new infected, I'm just replacing myself. And so the disease will stay constant. But if on average there are lots of infected people in the population and only some of us infect someone else, then the average basic reproduction number then is less than 1, and that means that the disease will die out. And so that's essentially what people are tracking. So if you hear about what R0 is, or R effective, or RT in the news, that's really what we're trying to track. Is how many new infecteds is one infected person making right now in this current point of time during the epidemic. And so what we do is we take this infectious disease data, or the total number of new cases by province or by the nation or by community, and we try to assess what that number will be. And so here we have all of the Canadian data, and what my colleague, so I work quite a bit right now with my colleague Matt Betty at Mount Allison University, and what we find is that if we try to fit this data to a model with the reproduction number, then we can get some idea of what the reproduction number is going to look like over different times during the epidemic. And so you can see that very early on, when we really only had some imported cases, the reproduction number, R effective here, was very small. And then we started to have some community transmission, and so then it went up. And this model is saying that went up to almost about 3. And then this is decreasing. You can see now it's decreasing over time because our physical distancing or social distancing is having an effect. And so that's what we want to see, is that this is going to decrease over time. But really what we want to see is that it's going to get really close to 1 and then down below 1. And that's when we can start to lift some of the social distancing measures and school closures or restaurants opening, things like that. So this is our model that we fit, but it's important to also understand that this is only one model. There are many models out there that can be used to determine what this reproduction number is. And some models say that we're already at that threshold of 1 or maybe a little bit below, and some models are saying that we're above that threshold. So we need to take all of that information into consideration, and governments need to take all of that information into consideration to determine when it might be okay for us to start relaxing some of the conditions that we have right now. Okay, so I mentioned before that there are lots of different things that we need to take into consideration when we're modeling coronavirus or COVID-19. And so here's just another extension that we would look at. So we have a SEIR, which we already looked at, but here we have our exposed individuals may become asymptomatically infected instead of showing symptoms. So we have them move over into this A compartment. And we also allow our individuals from our E and our I compartment. So as someone's starting to show symptoms, but mild, they might then go to the hospital. But someone might wait a while and then they start to show maybe severe symptoms, and then they will go to the hospital, which is right here. And then some people are going to recover. We're assuming that all people from the A compartment are recovering to R. And some people, most people, will recover from this hospitalized compartment to go to R. But then some people will also die of the disease. And then here we also have natural death and natural birth that we're involving. So that's looking at if everybody was the same, but not everybody is the same. So we're going to also include age and immune system status. So there are some people who have higher risk of severe infection outcome. So you can think that all of these compartments here actually have maybe 10 or 20 other subcompartments that we're going to keep track of. In terms of age, we know that this disease affects people differently depending on how old they are. And we know that this disease affects people differently in terms of whether they have some other chronic issues that affect them being able to deal with this disease if they're exposed to it. Then on top of that, you can think that through all of the age groups and through all of these other conditions, people are going to uptake different levels of social distancing. So we can then divide all of those other smaller compartments into many more smaller compartments to look at how effective social distancing is by age, and by immune system status or by health status. Okay, so there are lots of things to keep track of. But what do we know? We don't know all of this information. We only know what the media is reporting or what the government is reporting in terms of known cases or positive tests. So this certainly affects data quality. And this means that there are a lot of things in the mathematical model that are uncertain. So we need to really then figure out how to make our models as simple as possible while accounting for some of the complexities, so that when we fit our model to data and try to make projections, that those projections are realistic and they are something that can actually be applicable to the population that we're studying. So that's something that we call uncertainty. So then we can do a sensitivity analysis on all of the uncertainties to get a confidence interval to figure out how good our model is. If the confidence intervals are huge, then we need to go back and we need to change the model to get rid of some of that uncertainty. Okay, so I mentioned before that we've been hearing in the news that some people who are asymptomatically infected or mildly infected, their immunity that they've gained from infection might not be very long lasting. And so then we can add these other compartments down here, W for waning immunity. So you can move from the recovered compartment where you're assumed to be nice and immune to the disease. You can move to this waning compartment, and then you can then move to, if you're exposed here, you might then be reinfected, but then you probably have a higher probability of moving to the A compartment again, because you do have some immunity which will lessen your symptoms. And then, so on top of that, there's discussion. There are lots of vaccines that are in clinical trials right now. And so the idea is that if a vaccine is successful in being developed and being brought out to the population, if infection-induced immunity can wane over time, then vaccine-induced immunity should also be waning over time. And so we'll then involve this vaccinated compartment, and we can figure out by looking at this big model here, how often would someone need to be vaccinated to give them a maximum level of immunity to help lessen that risk of severe infection in the future. And so the idea is that even though this pathogen is not evolving very quickly, because the vaccine might not be very good in giving a sustained level of immunity, we may be looking at getting a vaccine on a yearly basis. Kind of similar to the flu vaccine, but the flu vaccine every year, what's inside the vaccine can change because the flu evolves over time. But this coronavirus so far has not been evolving very quickly. And so our initial vaccine for the first few years when one's developed could be the same until we might see some sort of evolution happening in the pathogen. Okay, so here are some case statistics. This is from January 15th to April 2nd of who the disease is affecting by different ages, and looking at the number of deaths and then looking at the case fatality ratio. So that's some data that we can use to fit our models to, as well as the number of new cases every day. And we can also get an idea of what the disease is doing by fitting to the number of hospitalizations every day as well. So here are some data that we can look at. We can try to inform our models what's happening for Ontario, say, and British Columbia, depending on what we've seen to be happening in other countries. So that's something that we can use to help project forward what might be happening at the national level or by province and territory. And we can use also the same level of information for deaths and hospitalizations and number of tests. Okay, so here's a simple model that we have fit to some of the data. So here on the left, these are the total number of cases in Canada over time. The black thick line here, that's actual number of cases that have been reported to the public and to government. And then what we've done is we fit a model where we're keeping track of mild cases and severe cases Um, we fit that model here, and then we projected that forward, where here we have some more data points that are here in red, but we're not fitting our model to those data points, and then we're comparing our model output to those red data points to see how good our projections are. And so here you can see we have known cases. So these are the cases in green that are reported. So these are all the cases that we know. But some of these cases are severely infected, and we're going to assume that all of those cases are reported, the severe infections, because they go to hospital. But we're only also seeing some small fraction of the mild infections and none of the asymptomatic infections. So using this data here, we're trying to figure out how many severe infections are there, how many mild infections are there, and then what can we get from this model is we can try to figure out when the peak will be. So this blue line is the severe infections, and it actually does go up and down, and we can figure out where the peak level of severe infections will be and the peak level of mild infections. And we can also then compare that to the total new cases per day. So this is the same model fit, where we also have data on the number of new cases that are reported every day. And you can see that it goes through these, the measured data, the black dots, really well. And then we compare it to where the red dots are, and it's still going through that red cloud pretty well, but it's on the high end. And so that gives us an idea of how good this model fit would be. We can use that to then project when the peak time of the epidemic would be. Okay, so here is a slide that the Ontario government provided in a slide deck to the public on April 2nd. And this is what some of the models were saying at the time, is that if we do not uptake social distancing measures, we'll have 300,000 cases. If we do uptake social distancing and we keep it the current level that we had at the time, we'll be seeing 80,000 cases in Ontario. And if we implement more mitigation strategies, then we'll be looking at 12,500. And what we did is we took the same model that I just showed you for Canada, and we fit it to the Ontario data. And you can see here that in terms of the green line, that if we project that green line forward, which are the known cases, that this model agrees with what the projections were for the Ontario data back on April 2nd, that we'd be seeing about 80,000 cases. We know that we're not seeing 80,000 cases, so that means that this model is not projecting using this fitting routine, not projecting what's actually happening. Or we can also say that this model didn't incorporate the new mitigation strategies that were put into place after April 2nd. And so what we then can do is go back and reassess the model and try to put in extra conditions of other things that we know or that we're gathering from other data sources over time. So that brings me to uncertainty and sensitivity analysis. So always we're thinking about how good the projections are and trying to figure out, using a sensitivity analysis, how sensitive all of the projections are to small changes in the data or in some of the parameters that we're fitting. So this takes me to the last thing. So this is something that we've been working on quite a bit during this pandemic. We're taking a disease model that incorporates mild infections and severe infections and all the different age groups in the Canadian population, as well as healthcare worker populations and people that are living with comorbidities and so on. And we're running disease models that look at many different scenarios for social distancing, school closure, self-isolation, and all of that over all these different age groups and other population subpopulations. So then what we do is with this disease model is then for every scenario, we look at the number of daily presentations to the healthcare sector that we would have, whether they're severely affected and they present to the healthcare sector early or late. And we look to see if they're mildly infected. And so then what we do is we look down here with outpatient presentations, this is where we're looking at the demand on all of our GP offices, our emergency departments, and in some of the provinces and territories on the assessment clinics. While we're doing that, we're also determining the cap or the maximum number of consultations that can happen at the provincial and national level for all of these healthcare sectors. So the GP offices, the emergency doctors, and the assessment clinics. And we're also trying to figure out how that affects how the healthcare workers are working in terms of shift length and whether they're working in an emergency department or an assessment clinic. So how we move workers from one place to the other. So what we also do then is after they see a doctor in one of these places, then it's determined whether a patient needs to have a hospital bed. And we then populate beds in the ICU, or if there are no beds in the ICU available, into the ward. And then this also depends on the level of symptoms that they have. And so then we populate the beds, and we populate them for a certain length of time, because we know on average how long someone stays in the hospital in one of these types of beds, depending on the level of symptoms. Then what we do with that information is we get an idea of the number of times a nurse or a doctor needs to be in contact with the patient. And then that means that we get an idea of how many gloves, how many N95 masks or goggles or visors or gowns are needed in each one of these healthcare sector settings by presentation. And so we look at also in terms of that, not just the doctors and nurses, but we also look at the receptionists and the cleaners, the social workers, the pharmacists, all of those people that work in the healthcare sector to try to estimate under many different scenarios what the different provinces and territories are going to need to make sure that they're going to be able to provide the treatment and care for all of their population that are affected by COVID-19. And so here's something that we can project. This is at the national level under a certain scenario for school closure and social distancing. And this is saying that we can calculate for that entire scenario the number of personal protective equipment bundles that are needed for all of these different settings. And what we've done here is we've summed them all up, and then we've projected what percentage of that total is going to be needed for different months. So here's month 1, month 2, month 3, month 4, and so on, depending on whether we have assessment clinics or not in our province and territory, and whether we are conserving. So the first bar here is whether we're going to conserve our PPE, so use it for longer periods of time, or whether we're going to change our PPE more often, or whether we're going to change it even more often. So you can think that this is a conservation type of scenario, which is actually being enacted in many provinces and territories now, whereas this high level of use is something that we would prefer to do, because this would then reduce the risk of infection of our healthcare workers. But this requires a lot more PPE, and in times like this, it's a lot harder to get all of these PPE into the country. And we know that different industries are being repurposed to make PPE, but there's only so much, or there's a limitation to the amount that can be made over time. Okay, so I'm just going to end with the same slide that I showed earlier that you didn't see. But here, I'm going to say there's some important quotes that are in the news. So it's important to remember that any model is not a crystal ball. And this is from one of my colleagues at the University of British Columbia. So that feeds to models aren't always right. It's not a crystal ball, but it's trying to inform to make evidence-based decisions. So another one of my colleagues from McMaster University said that he's glad that Ontario is making its modeling results available, though those results imply more confidence than is warranted based on all the unknowns surrounding the virus. So it's important for everyone to understand that there's a lot of unknown still about this novel coronavirus. and about how it's affecting all of the different people with within different age groups and with different comorbidities, and in different nations and different provinces. And so while we're able to use mathematical modeling to make some projections, there's still a lot of uncertainty. And that's where sensitivity analysis is very, very important. And here we also see on the right-hand side that the actual behavior of the outbreak in Ontario could be better or worse than the research suggests. So that really then feeds into what the assumptions are in our mathematical models, and then how that can be interpreted by the public and by government decision makers on what we should do next. If the uncertainty is more narrow, then we have a better idea of what's going to happen. But if it's broad, then we need to look at many different models and see how they agree and how they differ, and then make informed decisions from all of that analysis as well. So the last thing I'm going to say is that we want to really optimize the level of new knowledge from our mathematical model. So we want our new knowledge to reside on this peak here. And we can only get to this peak if we incorporate only a certain level of the biology. We don't, because as we incorporate more and more biology into our models, there's less and less data that we can get. And so it increases the uncertainty. So we want to reduce the uncertainty. We don't want to reduce it too far because we won't get any new knowledge from our results. It's an optimization problem. We want to reduce it to a certain level so that our mathematical models can actually provide some new knowledge and hopefully reside around this peak up here. So this model, or this work, has been in large part done with my collaboration with Matt Betty at Mount Allison University. The PPE modeling is something that we have done in adopting code from colleagues at the University of Melbourne in Australia. I'm going to thank here my lab members in the Modeling Infection and Immunity Lab at York University and the Center for Disease Modeling. And our work is being supported by, during this epidemic, the Public Health Agency of Canada, Health Canada, and StatScan. And our work is funded by the Fields Institute, the Natural Science and Engineering Research Council, CIHR, and this is the logo here for my lab within the Math and Stats department at York and the Center for Disease Modeling. Thank you. I hope I didn't go too long, and I hope that there's some time for questions. Thanks.
Thank you so much, Dr. Heffernan. I thought you made a really, really complex piece of work quite accessible and simplified for the layperson, and I really want to thank you for that. We do have a few minutes for some questions. I have one from Cheryl Davis, who asks, in addition to age, are you looking at male and female as distinct populations?
We have not yet. There's not much difference between the male and female population infection numbers right now. And in fact, that difference that we do see might mainly have to do with who in the household is running the errands. And I know in my household, my husband is the person that's going outside of the house. My kids and I have barely left the house just to go for walks. And so we've had no contact really with anybody else, but my husband has. And so that might be a reason why the male-female difference is happening.
It makes a lot of sense. Thank you. I have another question from Cheryl again, who's very engaged, wondering what's the most surprising thing you found in the data modeling you've done?
The most surprising thing that we found is really how stealthy this disease is in asymptomatic infections. There is a lot of unknown still with all of these asymptomatic infections, and people are working night and day trying to understand the burden that this puts on to the population. Well, another more interesting thing that we found in our modeling is how our modeling can help inform the supply chain for PPE. And so right now we're working quite a bit, my colleague and I, with Health Canada and Stats Canada to help inform that supply chain so that we have PPE that we will need for all the little rollouts or the little outbreaks that are going to happen with this disease in the future.
Great, thank you. I have a question about immunity, and this is a good one. I was thinking about it too. So Aneta Tasheva asked, the WHO recently announced that they can't confirm an individual who has recovered from COVID-19 is actually immune from contracting the virus again. And you yourself mentioned in your lecture about waning immunity. How does that impact the models?
That certainly impacts the models really, especially in initial conditions that we're going to see for all the different, because I'm sure that you've seen that we're going through this big peak, or we're trying to flatten that curve. And then the idea is that this disease is going to come back and going to be something kind of like the flu season that we see. And what we're interested in knowing, or what this waning immunity really has to do with, is trying to figure out how many people are going to be susceptible at the beginning of the next season of coronavirus infections. And if there's a vaccine that is available at that time, then we need to make sure that we vaccinate enough people with that vaccine, even though that vaccine might not be very effective in providing immunity. It can at least boost immunity in everybody's bodies so that you have a higher level or higher probability of a mild infection if you are exposed to the virus. And so trying to get an idea of the picture of how waning immunity is happening over time, how long lasting it will be, and how effective it will be, will then help us inform what our initial conditions will be for when the next wave of infection will happen.
Great, thank you. So we have time for one more question, and I have one from Valerie Sterling. Do we know what the age group of those, with mild infections? So you showed a slide earlier that had it broken down by infection or death rate, but this is an interesting question.
So that is a really good question. We know that children aren't very affected by this virus, so much so that in many provinces and territories and in different jurisdictions, that when it is believed that a child is affected with this disease, but not severely, we won't test them. And so that means that we actually have very, very limited amount of data on how this infection is affecting people with mild symptoms, because we're not testing children. And so that provides a lot more uncertainty, and especially there's lots of discussions about opening schools. And because we have lots of uncertainty in how this is affecting children, that means we have a lots of uncertainty of what will happen when schools do reopen, in terms of transmitting the virus to people who might be severely affected. So like grandparents or teachers or school bus drivers. So those are things that we need to make sure that we understand more. So no, we don't know a lot about what's happening in asymptomatic infections because so many of them are not reported and are not tested. And it's even down to the fact that someone who is asymptomatically or mildly affected by this disease, they don't know if they just had a cold or if they had this. And we're not going out and testing everybody. We need to make sure that we're testing the people that need to be tested, that get into the healthcare system for treatment.
Thank you so much for that. I'm getting other questions about the video and the recording of this lecture, and that is available on Facebook right now, everyone. So if you look for our Facebook page, just search YorkU Alumni, you'll find it, and please do share this with family, friends, and others who may find this topic really important, as all of you do too. So thank you, Dr. Heffernan, really a pleasure. Thank you for taking the time out of spending time with your family to be with us today. I really appreciate it.
Thank you very much. It was a pleasure, and I'm sorry about the slides not showing up in the beginning. And so I can offer to share those slides with people if they want to see them.
That would be amazing. Thank you. I'll have one of the team connect with you for that.
Okay. Thank you very much, and stay safe, everybody.
Thank you.